So we arrived at the scene and there is no danger. So we asked for response type, sir, can you hear me? And the patient is not answering. So we look at the airway and it's clear. So we listen for breathing for 10 seconds. Okay, the patient is not breathing. Can you please provide help?
A2 patient is R45 with for 50 days.
Can you please do the conclusions?
Connect electrodes.
So while we're doing this, we ask if anyone knows the history of this patient. Does anyone know this patient?
Push analyze. Push analyze. Motion detected. Stop motion. Analyzing now. Scan clear.
Everyone stand clear?
No shock advised.
Yep.
Start CPR.
So we entering for the OSCE or section if needed. Then ventilate for 2 breaks. And then see the chest right. And then we'll sort over.
Chest rise. Chest rise.
So now we're gonna check her lungs using stethoscope. So we're gonna check her anterior, posterior lungs, also her superior lobe and inferior lobe. We are looking for the clarity, whether the 2 lungs are clear while breathing. So Joe, we're gonna measure your lungs using stethoscope.
Yeah.
Okay, we're gonna check for the front and back, and also top lung and bottom lung. Okay, we're gonna just only check for a few seconds.
Yeah.
And we're gonna put a stethoscope on your skin.
Yeah.
Okay, is that alright?
Yeah, that's alright. Sure.
I'm going to tell you to breathe deeply in and out. Okay. In. Out. In. Out. We're gonna follow up. In. Out. Inside. In. Out. In. In. Out. In. Out. Outside. In. Out. So her lungs are both clear, don't have any noises while breathing, so she's fine. So now we're gonna measure her radial pulse rate. So her radial pulse rate is beneath your thumb. Yep. Yep. And then we're gonna measure for 50 seconds and then times by 4 to get 1 minute radial heart rate. Also, we're looking for the strength and regularity. For the following 50 seconds, we're gonna measure her respiratory rate by looking at her chest right, and we're also looking for the regularity and whether she has a noise while breathing or not. Yep. Okay, her pulse rate is 20, so times by 4 is 80. The normal range is between 50 to 100, so she's fine. And her pulse is strong and regular. Her respiratory rate is 5 times by 4 is 20. So the normal range is between 12 and 20, and she's also fine. And her respiratory rate is regular and don't have any noise sound. Yes. So now we're gonna measure Joe's blood pressure. So the normal blood pressure range is between 90 to 120. So systolic 120 above is hypertension, high blood pressure. Then below 90 is hypotension, low blood pressure. So Joe, I'm going to measure your blood pressure.
Yeah.
Okay, please remove the distracting clothes. So I'm going to put the stethoscope on the middle side of her inner elbow. So it's here. You will feel about tight. Then release. So we'll hear the first beat is your systolic, and then we cannot hear the beat is your diastolic. So her number is 110/70, so she's in a normal range. Okay, and then the systolic blood pressure is the pressure during ventricular contraction, and the diastolic is during ventricular relaxation. So today we're gonna use OPA. So OPA is when the patient GCS score is under 8 and the verbal response is under 2 or 2. Yes. So there are different sizes of OPA. So to measure this, we go from the corner of the mouth along the angle of the mandible. Okay. So to insert this OPA, we first turn it up, and then we insert 180 degrees on the roof of the oropharynx, and then twist 180 degrees. And then to avoid catching the tongue. And then to assess the patient if they accept the OPA or not. So the complications induce vomiting. If the OPA is too large, then will cause damage to the oropharynx, or worsen the airway obstructions by pushing the tongue positioning if it's too small. Okay, now we're gonna use MPA. So when we use MPA is when we cannot use OPA and the GCS score is high. So to measure the NTA is same as OPA. So measure from the nostril to along the angle of the mandible. So we choose the largest nostril. So to insert this, we use we lubricate the NTA by using a water-based lubricant, and then we insert this. Okay, we insert this about 90 degrees to the patient's face. If there's resistance felt, then we rotate 180 degrees. If the resistance still felt, then we try the other nostril. So I insert until the flange reaches the nostril. The complications of MTA is bleeding, nasal polyps, and the contraindications are suspected basal skull fracture. Now we're going to demonstrate the backbone mask. First we put our PPE gear on. Second, we look at the patient's airway. It's clear. Then we insert a OPA to help open the airway. So we first measure from the corner of mouth, the angle of the mandible. Then we insert this, we tilt it up, and then we insert halfway of OPA, and then twist 180 degrees in. So now we're gonna do the tube. So oxygen delivering tube onto the valve of BVM. Yes. And then we turn on the oxygen delivering thing 10 or to 15 liters per minute, and then see the reservoir is filling. Then we check whether the tube or the connection is not leaking. Then we place the mask on to the patient by doing a CE grift. Do a CE grift, and then we'll ventilate the patient. One ventilate in 5 or 8 seconds, and then see the chest rise here. So if needed, one person holding this mask and other person can do the quick core pressure. If I ventilate the patient too fast, then will affect the blood circulation. If I ventilate the patient too much oxygen, then will cause vomiting. Then it's gastro inflation. So today I'm going to demonstrate oxygen delivering. So this is the oxygen tank, and this is the regulator. So first we're gonna check the oxygen regulator. So this is bolt itself. We're gonna check it's not real or ripped, otherwise it's not functioning properly. And then we're gonna attach this to the tank. Yeah, by tightening it out. Yep, and then we open this to see there's enough. The readings is on the red thing here. Oh, refilling. We need to refill, but it's enough for this demonstration. So we're gonna check whether there's oxygen or not. Then we just turn it on. Yes, there it is. Then we place the mask tube attached to the oxygen tank. Yes, and then we place the mask on the patient. And then make sure it's sealed down, and then tighten the seam if needed to avoid any leaking of oxygen. Then we turn it on, and it depends on the condition of the patient. When we finish, we unmask it, the patient, and then unattach the tube from oxygen delivery, and then we close the tank, and then rush out all the releasing oxygen. Yep. Thank you. Yeah. So today we're gonna use the suction. We're gonna test the suction first by turning on this full. Yep, close the circuit. And then watch the light about 350. Yeah, and we're gonna test for build the suction. Yeah. So this all good. So we insert this first. We're gonna open the patient's mouth, put her in a lateral position, and then we insert the catheter as far as we can see the oropharynx, and then we suck on the way out in a circular motion like this. And then we can also use this rigid catheter in a moving vehicle, and we cannot use this for more than 10 seconds because otherwise the patients will cause hypoxia. Other complications are causing the soft tissue damage of oropharynx and aspiration, induced vomiting, and bradycardia. Yeah. Today I'm going to do the hemorrhage control. So first we're gonna explore the wound. So ask for consent. Hi sir, I'm going to have a look at your wound. So this means I'm gonna touch you. Is it alright? Yes. And then we just clean the wound by C-lines. So we just clean it, right? And then we just also use a dressing to moisture. Dressing. Yep. And then we're just gonna fold it as small as possible to cover the wound. Here. And then we just put a bandage on. So we tighten the bandage each time it travels over the wound. And then we also do crossing over and a twist to help tighten it. So we're just gonna tie as tight as possible. So if it's still bleeding, so we can apply another dressing and bandaging, and we also can put the bandaging underneath their arm and then lift the arm to stop the bleeding. So for the catastrophe control, we apply a tourniquet to the patient, so 10 centimeters from the wound. So we're just gonna apply this to him, and then we tighten it up. Yeah, we're just gonna tighten it up, and then we twist the witness. Yeah, and then we just have to write down the time when we tighten this, and if it requires, we can apply another tourniquet. Today I'm going to demonstrate in the C-collar. So first we're gonna assess the Nexus assignment. So basically it's a national emergency X-ray utilization study. So the indications are no posterior midline cervical spine tenderness and no evidence of intoxication. And mental status is 5 out of 5 verbal score, and no neurological deficit, and no painful distracting injuries. And this is for temporary support to the hip. So we need to put the C-collar on this patient. First we're gonna ask for consent. Hi sir, we're just gonna put this C-collar on you to support your neck from your injury. Is that alright? Yes. And then we help colleagues please hold his neck. So we're gonna measure it from the joint to the bottom of the neck to measure the collar. So there's 5 fingers actually. So we're gonna measure from here to here, and we adjust the C collar by doing that. So we're gonna put the C collar on you. So first we're gonna remove all the distracting clothes and the earrings and necklace stuff. So we're gonna put it here. So we just put the chain has to be on the pouch, and then this is how you stabilize the patient's neck. Now we are doing demonstrating ECG. So we check the battery at the back. So should be like 2 batteries here, and then we simply turn the monitor on.
Push analyze.
We select the menu mode and press yes, and then we turn for 50 joules, and then we do an operational check. So we press options, and then do user text, and then just wait for the paper to print. So the paper is finally out. So we just this off, and this is user test passed. So it's passed. So if we want to change this, we just simply open it, and then there should be some at the back. So after the check, we just press charge, and then press the shop button. And the image is delivered. So we change to AD mode.
Analyzing now. Stand clear. No shock advised. Start CPR.
So we change the lid. So we change 1 or 2, 3 or AVF or PET. Doing this. Changing that. Stop. So for the QRS volume, so we just select heart rate, and then this is QRS volume, and then you just raise and then lower the volume like that. Yeah, and then for the ECG sides, just select this, and then the sides here, and then just select sizes. And then for the NIVF, so this is the blood pressure, and also the ETO2 is here. It's located here. Hi, today I'm going to do the fracture management, so the splinting. So first I'm gonna explain the procedure and gain the consent of patient. So sir, I'm just gonna explore the injury or fractured leg, and we're just gonna do the assessment on you. So is that right? Yeah, he said yes. So we use the history and the plastics acronym to determine the likelihood of the fracture. So we assess the cardiovascular and the neurological integrity. So by touching his toes and feel the temperature of his toes and compare the color. So we always look at the injured leg and compare the uninjured leg. Yes, and then we do the capillary refill, and also ask if he can actually move his toes. So we're gonna do the pain score assessment. So by asking the patient the score 1 to 10. So 1 is the least pain, and 10 is the worst pain you have ever had. The patient answer is 7. So this patient has a pain score of 7. So we're gonna give him the analogs. So anti-locks contraindications are unable to obey commands, suspected pneumothorax and bowel obstructions, and also diving within in last 24 hours, also known as allergy. So sir, I'm going to give you anti-locks, so you will feel a metallic taste and lightheaded and echo sound, and this is completely normal. So we just gonna give him the anti-locks, just turning this on, and then we ask the patient to breathe in the anti-locks, and then until he cannot feel the pain or pain has going this pain. So we're gonna put this splinting on my patient. So before it's look like that, splinting, and then we just gonna fold it like this. Yep, and then we ask for consent. So sir, I'm gonna put this splinting on you. So we put a towel. And put a towel over the splinting to make it comfortable.
Mm-hmm.
So now I'm going to lift your legs. Lift your legs very gently. Is that right? Yes, yes. Yeah, and then put the leg in the splinting. And to support and stabilize, we use the sling to support it and stabilize it. And tight the sling. So after we done this, we're gonna do the cardiovascular and the neurological assessment.